Hello to all the respected members of Indian Society of Anesthesiology. It gives me immense pleasure to have the chance to present a case of a post-COVID mucormycosis posted for bilateral face and bilateral resection. Without further ado, I'll dive right into the discussion. Here we all know at the end of devastating second COVID-19 pandemic wave, there had been a sudden surge of post-COVID rhinoorbital mucormycosis cases which were taken on national emergency, and every case has to be operated with the highest priority and with minimum optimization of the patient. Here we report a case of a patient with a post-COVID-19 infection who developed rhinoorbital mucormycosis. A 54-year-old male patient with a bilateral lung fibrosis was admitted with the complaints of pain and swelling in left upper jaw since a week. He was admitted post-COVID for almost 63 days in our institute in RICU and was exclusively on NIV for 20 days and then on bag and mask and NIV ventilation intermittently. He was long-standing hypertensive and diabetic and was on the treatment for the same. He was on oral antifungal as we found him allergic to the amphotericin B. On examination, he was conscious oriented but was febrile and irritable. He was having tachycardia and tachypnea with the use of axillary muscles for the respiration. His all routine investigations was within normal limit except the hemoglobin which we found less than 10 gram percent. On special investigation, his arterial blood gas analysis showed decreased PO2 levels and HRCD score was 25 by 25. His CCT-PNH was suggestive of right and left maxillary sinus sinusitis. We took this patient for the surgery under ASTEC rating 3 with the high risk concern explained to the relatives. We shifted this patient to the post-op room, to the operation room on the O2 support with the nasal pumps at the rate 3 liters per minute. We pre-medicated this patient with the injection glycopyrrolate, midazolam, and fentanyl. Pre-oxygenated this patient with the 100% O2 for 3 minutes. Induction was done with the injection etomidat and succinyl. We used attached nasal prongs at the rate 15 liters per minute while intubating the patient. Intubation was done with the conventional laryngoscopy with the endotracheal tube number 9 and airway was secured and throat packing was done. For maintenance, we used injection vecurine as a muscle relaxant with sevoflurane and oxygen was used. Intraoperative patient was vitally stable, but he required high PEEP support and high ETCO2 levels was observed. We did check bronchoscopy with a flexible disposable osmoscope which was available in our institute and simultaneous suctioning just before P extubation was done. We found bronchial mucosa flooded with the mucus and patches of blackened thrombus till the terminal bronchi. We reversed this patient with the injection glycopyrrolate and neostigmine and extubation, and just before extubation we observed him for 10 to 15 minutes on TPs. We observed fall in saturation to 80% while discontinuing the circuit. We successfully extubated this patient and kept on nasal pumps at the rate 3 liters per minute, which decreased to 2 liters per minute after 24 hours. His ABG showed increase in the PO2 level after post-operatively. We discharged this patient on 2nd of the August with the oxygen support on nasal pumps at the rate 2 liters per minute after making availability of the O2 support at his home. So here patient was having lots of systemic COVID-19 complications along with the hypertension, type 2 diabetics and amphotericin B induced reaction. So medical use of anesthetic drugs, lung protective ventilation strategy, bronchoscopic suctioning improves post-operative outcome and O2 requirement in post-COVID mucormycosis patient. We explained that pre-reversal bronchoscopy found to be helpful in decreasing post-operative oxygen requirement as compared to pre-op oxygen requirement. Thank you.